I'm Dr. Michael Thorpe, Director of the Sleep-Wake Disorder Center at Montefiore Medical Center and Professor of Neurology at Albert Einstein College of Medicine. I'm here with my good friend, Yves Dauvilliers. Yves?
Yes, happy to be with you today. I'm Professor of Neurology and Physiology in Montpellier, south of France in Europe, and interest a lot in sleep medicine for decades.
So today we're just going to chat a little bit about some of the features of idiopathic hypersomnia. And there were some questions that came up from people about some of these topics. So let's start talking a little bit about symptoms of idiopathic hypersomnia. The symptoms are a little unusual in that we talk a lot about sleep inertia and brain fog. What do you think about those symptoms, Yves? How common are they in idiopathic hypersomnia?
Yes, they are very frequent symptoms and most disabling problem for patients with IH, mostly in the morning when they wake up, for sleep inertia after wake up during 1 hour, at least 3, 5, even time a week, and even on a daily basis, they complain a lot. They are clumsy, they are drowsy, they are very slow. And this is sleep inertia that may exist after nighttime sleep and sometimes even after naps, when naps are quite long. Brain fog is a little bit different. It is all day long. They are foggy. They are problem to think, to remember, to have a good cognition performances, but it's nothing to do related to the sleep just after waking up, after naps or nighttime sleep, but they are often associated together.
So somebody was asking about what is the difference between brain fog and a sort of cognitive dysfunction, I guess a neurological cognitive impairment. How would you distinguish that from brain fog, would you say?
Yes, it's a good point. It's quite hard to really quantify that. It's mostly a complaint, a perception of being slow, being confused, being not very accurate. But when you do some cognitive test, executive test function, memory test function, and orientation in space, in temporal orientation is mostly correct, but they are slow. They are not very it's not they are wrong, they are accurate, but they are slow, and but it's very hard to quantify that. Unfortunately, there is no good test. What do you think, Michael?
Yeah, do you think they have more variability with brain fog? Does it sort of come and go, at times get worse, whereas a sort of a neurological cognitive dysfunction might be more constant? What do you think?
Yeah, I agree. It may wax and waning, and I do agree with that. It's mostly a perception, a complaint. And again, when you do some cognitive test, it's mostly normal in this subject. So it changes time to time during the day. Sometimes they are drowsy, sometimes they want to go to sleep, sometimes they have problem when they wake up. It's they are confused, they are very slow, and but again, it's very hard, and it's a little bit difficult for me because we rarely use this term in French language because it's hard to translate as well. Sleep inertia is quite robust, but brain fog is very heterogeneous symptoms, and even between subject and for a similar same subject as a function of time in the morning, on PM, on evening, is very variable.
Now, both of these symptoms can also occur in narcolepsy, and sometimes it may be difficult to distinguish between idiopathic hypersomnia and NT2 narcolepsy. What do you think are the sort of key elements to help distinguish those two disorders?
Yes, excellent point, Michael. We love to say that patients with narcolepsy are refreshed after nighttime sleep, after naps, and with dream content. And when they are awake between 2 naps, they are perfectly in a correct awakening. They are alert, but it's not completely correct. And when you and we did publish that 2 times, that when you look for sleep inertia in IH patient compared to narcoleptic patient, and even in OSA subject or sleep deprived subject, that exist. Sleep inertia exists The problem is the duration, if it's 1 hour, 2 hours, if it's again on a daily basis. And sometimes the patient may complain when they are sleep deprived for 10 minutes, 20 minutes, and just 2 times a week. So again, it's a question of threshold, duration, severity. So I may say that IH patients have often prolonged and severe sleep inertia, but that exists in other conditions, is not specific at all. And even in narcoleptic patients, you can see that, especially in young subjects, in young adults. In elderly subjects, is a little bit probably less frequent.
Right. And I always ask all my patients who have hypersomnia whether they have brain fog. And, it's good when you ask them specifically about that, because for many patients who are not familiar with hearing that sort of term, they get really quite excited when you bring it up, because they feel that that really explains what they're going through every day. Nothing is sort of clear. They have this, lack of coordination and perception. And so it's an important question to bring up in narcolepsy and idiopathic hypersomnia. But of course, one of the main distinguishing features of idiopathic hypersomnia, for some patients anyway, is that very long sleep time that they have in the 24-hour period. And you just don't see those long 10, 11 or longer hours of sleep in one bout in patients with narcolepsy. I mean, typically they have a more disruptive sleep and with more frequent awakenings, and have a more normal duration of sleep compared with the IH patient. Do you think IH is, would we call it a sleep-wake dysrhythmia, Eve? Is it a really, I guess it is really. I mean, we have either this long sleep and sometimes very sleepy during the day, but it certainly is not a normal sleep-wake cycle pattern. So what do you think? Would you use the term sleep-wake dysrhythmia for IH?
No, I rarely use that myself. I think that if we want to be very punchline and very take-home message, mostly narcolepsy is a wake problem. They have problem to be awake, to be alert. And in contrast, IH is really a sleep problem because they cannot fight again. They are always sleepy.
Right.
But I rarely use the sleep-wake disorder contrast to circadian rhythm. In IH, again, it's very heterogeneous. We like to merge, and even in the last ICSD-3 text revised, the TR just available a couple of weeks ago, it didn't change that too much, unfortunately. And we mix patients who are very sleepy during the day in NREM, so without any REM sleep problem. And in contrast, patient may have a long sleep, as you just mentioned, with sleep inertia when they wake up, but not very sleepy during the day. They complain of sleepiness for sure, but they can have problem to fall asleep quickly. They can fall asleep in 10, 15 minutes, but after it takes hours to wake up. Contrast to narcolepsy, they fall asleep in 5 minutes, and that take just a couple of minutes, and after they are mostly refreshed. This is typical, but again, we do see a lot of overlap. And as you know, there is a lot of patient with NT2 that may be diagnosed with IH later on, and vice versa. So it's not very robust so far, the criteria we used.
Right. Those long sleeper IH patients, as you say, I mean, sometimes if they get the amount of sleep at night, then they're relatively alert during the day and not complaining of really excessive daytime sleepiness. But of course, it's very hard for people to sleep 11 and 12 hours every day, because everyone has commitments, either work commitments, social commitments. So what happens is that when they have a much shorter sleep at night, then they really notice the sleepiness more during the daytime. So that sleepiness does fluctuate in those long sleepers. Many people think of IH as being like a second-class narcolepsy disorder, and that the symptoms are not as bad. But patients with IH can be as badly affected as patients with narcolepsy, even narcolepsy type 1, can't they? They can be severely sleepy and their whole lives can be very disrupted. What do you think?
Yeah, I share this statement for sure. The consequences of having IH or narcolepsy may be very severe, with a lot of disability in terms of work, in terms of familial issue, in terms of social issue as well. Because if you need to sleep 12 hours at night and 2 hours or 3 hours during the day, you have very few times to deal with your daily life. And even again, between naps, you are not very in good shape. You are very drowsy. So it's an issue, because the diagnosis is not often made in a good way. The management is not often made in good way. So the disability is very huge also, because it's an orphan disease and not very recognized by the society, and there's a lot of stigma on that as well.
Right. You know, a lot of the difficulty, of course, of recognizing IH is because of the diagnostic criteria. I think they're a little confusing for a lot of people. And, you know, I think we all feel that there could be some improvement for the diagnostic criteria, but I don't see it coming in the near future. Do you, Eve? Do you think there's going to be any change in you know,
Europe,
within a
yes.
short period?
In Europe, yes. Hopefully,
Yeah.
in France, it's done already, because we recommend in the reference center to do the long sleep recording, at least 24 hours,
Right.
to look for the long sleep recording to assess the prolonged nighttime sleep, and to recognize the one of the key parameters from IH, because mostly in US they perform just MSLT, and because of insurance companies. So I think more and more in France, we convinced the government that we need to do this long sleep recording at least once a lifetime to confirm the diagnosis. So I don't know if it will change as a world level because of the cost. But again, the cost, you know, for the medication is very large. So why do not make the cost for the diagnosis at least once a day?
No, I would entirely agree with you. I think the cost is really not the issue when you're dealing with a disorder that can last a lifetime and has such a serious impact on people's lives. So, now doing the long 24-hour sleep recording or even longer, I mean, certainly is helpful for those people who have prolonged nocturnal sleep. But what about the people that look more like the narcoleptics, that have a shorter nighttime sleep, have the daytime sleepiness, but don't have the abnormal REM phenomena? Then, you know, the 24 hours is not going to help much more, is it, than what we have now with the PSP and MSLT?
I do agree with that. I think the first step is probably to do the PhD MSLT, also to look for sleep abnormality, sleep fragmentation, the wake time after sleep onset, the sleep onset REM period, the predict leg movement, a lot of the NREM, also sleep fragmentation that may favor parasomnia as well in NREM. So you need to do the PhD, and because there are complaints of sleepiness, to do the MSLT to exclude also either narcolepsy or nothing with sleepiness during the day. If the MSLT is more than 15 minutes, probably the story is over. You don't need to go ahead. But if the patient is between 8 and 12, but I don't want to make too much the cutoff because it could be 13 for some of them, but I may say mostly between 8 and 12 minutes, they are not in the criteria for MSLT and for an IH. So for this subject, I think the second step is to record the 24-hour sleep recording to look for the prolonged sleep.
Now, how about orexin levels, Eve? I know you've done a lot of work with orexin and IH and other sleep disorders, hypersomnia. So, do you think it's helpful in any of the cases of suspected IH?
So excellent point, Michael. For NT1, it's clear, it's highly associated. NT2, so without cataplexy, again, narcoleptic patient, it's 20, in my experience, is 20, 30% with low orexin level. And mostly physician within sleep lab in the world, especially in US, but also in other part of the world, they rarely do orexin measurement in routine. So they just call that NT2 because there is no cataplexy. But I believe me that in 20, 30% of them, they are with in between or low orexin level. For IH, the diagnosis of IH is mostly unstable because with 1 SORM and 7 minutes for the MSLT, it's IH. But if it's 2 SORM and 7 minutes for the MSLT, is NT2. And in between, there's just 1 SORM differences. And we do know that the SORMs is very variable and not very stable between 2 consecutive MSLT. So I may say that in some cases of IH, it is of interest to look for orexin measurement. So it's mostly for the IH without long sleep time with short abnormal MSLT, especially if there is 1 or 2 SORM. For the prolonged nighttime sleep, so the IH with long sleep time, no, I think it's out of scope and it will be normal in mostly 99% of cases.
And do you think the presence of either a low orexin or a sleep onset REM periods makes a difference in terms of treatment? Now, I know medications are a little bit different from country to country, but what about an NT2 patient versus an idiopathic hypersomnia patient? So you got the NT2 who may have abnormal REM phenomena, the IH who doesn't. Does that make a difference in terms of what you're going to choose for treatment?
I think yes, because of the comorbidity and the associated symptoms. Again, mostly patients with IH have sleep inertia, prolonged nighttime sleep, and the sleepiness during the day may be in between, sometimes severe, sometimes not. For narcoleptic patients, they are always associated with severe sleepiness, and they may have sleep paralysis, hypnagogic hallucination, and for NT1, cataplexy. So I think the objective is not just to treat sleepiness, is to treat all of these other symptoms, and they are not the same, again, as I just briefly sum up. So yes, it will change if you go to wake-promoting agents, to antidepressants, for the REM sleep phenomena, or even the oxybate, that is nice treatment option. But it depends on which symptom do you want to treat.
Yeah, we now have oxybate. Of course, the low sodium oxybate's been FDA approved in the US. I don't think it's approved in Europe yet, is it, for IH?
Yes, that's a pity because we were in the study, and I'm the first author of this Lancet neurological nice paper that showed that Xywav, so the low sodium oxybate, is very effective and well tolerated in IH patients, but unfortunately it's not approved in Europe because it's just one study and because there's no objective measurement, there is no PhD MWT, so it just self-report assessment. So it's lovely study, it works in my patient because we were lucky to have a 1-year follow-up after this double-blind study. So we have experience with this medication in IH, it works, it's nice, but it's not available, unfortunately, in Europe.
So what would be your first go-to medication for IH in Europe, Yves, if you don't have oxybate available?
So we do not have oxybate available, and low sodium oxybate is not available at all in Europe, but we can use oxybate, so the Xyrem, the classic Xyrem, because there is no one drug, for IH, and in US is almost the same story, because if you two years before, even 1 year before, probably you use modafinil, solriamfetol, pitolisant, methylphenidates off-label. So we continue to work in this direction. When you diagnose patient, you manage the patient, even if it's off-label. So we have the same drug as you have, except the low sodium oxybate and the once nightly as well. It's not yet approved.
Unfortunately, because many medications are restricted, and some of the ones that you mentioned are only restricted to narcolepsy, the solriamfetol, pitolisant, that people often, when they have IH, will tend to lean more towards calling it narcolepsy type 2 rather than IH in order to be able to get these types of medications. So it's most unfortunate that we don't have a full range. We only have that one drug, low sodium oxybate, that's FDA approved for idiopathic hypersomnia. And do you think if you use, and you have a lot of experience from the research trial with the low sodium oxybate, is there any difference in the way it affects idiopathic hypersomnia than, say, narcolepsy type 2? Is there a more prolonged effect of the medication in IH versus NT2, or is it the same, or does it work differently for IH than NT2?
Yes, you raise good points. I'm not sure I will be able to answer based on literature, but with my experience, what I can say is when you manage with low sodium oxybate patient with IH, it's very nice to decrease the sleep duration and also the sleep inertia, because they are forced to wake up because the drug is working for 3 hours or 4 hours at maximum, and after the second intake they wake up. Even after the first intake, sometimes they have no problem to wake up in the middle of the night to take the second intake, because the half-life of the drugs force them to wake up. So it's good for the IH with long sleep time to work on EDS, but also on sleep inertia and prolonged nighttime sleep. This is my experience. However, in the paper we did publish in Lancet Neurology, it works in the same range in IH with and without long sleep time. We make some sensitivity analysis on that, and it seems to work in the same way, like as a function of the age, as in males or in females. So we play with the data to answer that. For NT2, I think it's there is few studies focusing just on NT2. It's mostly a mixed bag, NT1 and NT2. So it's hard to say. And mostly it may restore and change and decrease the shift between sleep stages in NT1 and NT2, and especially to increase N3 and decrease the transition with REM sleep. And last point is that unfortunately so far I didn't read, and probably because that not exist, any good studies on oxybate in IH in terms of polysomnography, how it works, how it changes really the sleep architecture in IH.
Yeah, we need that information. Now, with new treatments that are coming up, of course, there's a lot of excitement over the orexin agonists, particularly in narcolepsy. And as you mentioned earlier, the IH patient usually has a normal CSF orexin level. What do you think about orexin agonists and going forward when they eventually become available? Do you think they could be effective for idiopathic hypersomnia?
So I think yes, based on the recent paper published in Sleep by Emmanuel Mignot with the TAC925 IV. So it's just a preliminary results because it's IV and the drug cannot fit with what the patient needs. It's not oral drugs. But the proof of concept show that regardless of the level of orexin, the drug is effective. The dose probably required to be effective will be different as a function of orexin background in the CSF, so in your brain, but it works. And I buy this hypothesis because, we play with dopaminergic activity with the wake promoting agent, or even the histaminergic activity with the pitolisant, and we never showed that there is dopaminergic change or an histaminergic problem really in narcoleptic patients. So it may work regardless of the background of orexin level, because it's a wake promoting agent functioning on orexin receptor 2.
Yeah. Well, this is a very exciting time for narcolepsy and idiopathic hypersomnia, because we've got so many new medications that are currently being studied, and then we have this future prospects of the orexin agonists coming up. So there's a lot that's going to be happening over the next few years with narcolepsy medications. Well, I thank you very much, Eve. This has been a wonderful discussion. I think we've covered a lot of really important points here, and it's been great to talk with you about this. So thank you very much, and thank you, the audience, for watching them.
Thank you.